Today, I'm going to be speaking to you a little bit about quality improvement. And quality improvement is really a methodology or a way of thinking, essentially a framework for how do you approach how to solve the problems within really any industry. I happen to work at a children's hospital, and so I'll talk about how that framework applies in the really complex environment of healthcare. But I think you're going to be able to see that there's a lot of generalizable truths that you can apply to really any area or really any industry. And so at the very end, I hope as I wrap up, you'll be able to see how you can do that. Okay? If you have any questions at the end, I'll be happy to take some. So, just a couple of acknowledgments. I just want to thank Brent James, Jane Lavelle, Brooks, and Ron Karen for some of the slides that I put together here. A bit about me. So I am not a doctor. Okay, I work at a hospital. I'm not a doctor. If you have any medical issues, do not ask me. Okay, go to a doctor. But my wife is a doctor, so that's actually where I go for my medical advice. And my daughter apparently wants to be a doctor, but it's a hard road, so I would probably discourage her and encourage her to go into maybe international relations instead. But in healthcare management, and I manage a data team in quality improvement, so I'll be kind of speaking about how do you bring data in as an objective truth to a process and how that can actually drive improvement forward. Philadelphia is a phenomenal place. It's really the birthplace of America, and so there's a lot of historical firsts. And so one of the historical firsts is the first pediatric standalone hospital was started in Philadelphia, and a lot of great research comes out of our hospital. We're a fairly large hospital, and we're ranked either number 1 or number 2 in the US. I'm going to talk to you a little bit about US healthcare. It's actually not as great as you think it is. Talk about the limitations of traditional medical decision-making, kind of jump then to manufacturing quality improvement theory, and then kind of bring that back into how that quality improvement theory can relate to healthcare. So the United States is here in terms of the cost compared to infant mortality, right? So infant mortality is the rate in which babies die, right, when they're born. And this is basically the message here is it's really expensive in the US, and they have a really high mortality rate when it comes to healthcare. This is something similar as well. Here's the US, extremely expensive, but their life expectancy is not where you think it should be. And here is Western Europe, Japan, Eastern Europe, right? So you're spending all this money, and you're not necessarily getting the returns that you want for spending all that money. They estimate about 18% of GDP is spent in the US on healthcare alone, and that cost continues to rise. And those of you guys who are from business, 18% money if you think about the US economy. Again, here, you see the US spends a lot as Americans get older, right, compared to other economies, other countries. And over here, again, the US ranked number 11 out of all these other countries in terms of quality of care, and still really expensive. I think you get the message here, is that just because you spend more in healthcare, it doesn't mean that you actually get better healthcare. So why is this happening? Well, one reason is because the US is really good at rescue care. They're really good at saving your life at the end of your life, which is nice. You can spend lots and lots of money to live maybe a week longer. But don't you think the money would be better put in terms of just building a healthier lifestyle, right? So in terms of population level, the US does not spend as much or care as much about the population health. And what does that actually look like? What it means is the doctors that are most valuable are the doctors who are specialists, like dermatologists or ophthalmologists or radiologists. And the people who are not as valued, perhaps the doctors that you see, the family practice people or the primary care physicians, they are not as valued, right? The thing that's going on is that physicians are paid by volume. So that means the more care you give, the more you get paid, regardless of how well you deliver that, right? So that results in more tests, more imaging, more labs, right? More procedures, but that does not mean better care. And so this is a huge problem in the US and something that we realize that we need to fix. And so now I'm going to turn to just medical decision-making in general, because how doctors have performed for centuries is now coming to a head with how much knowledge there is in the world. Okay, so when you become a doctor, how many of you guys know doctors, right? The smartest and brightest people that you know, right? And yet, they have limitations, right? And so doctors are trained that based off their academic training, the experiences they get in clinic or in shadowing physicians and just seeing other patients, right? That experience will allow them to make the best decision. And so they talk about the art of medicine, right? When a physician looks at a patient, you are special and they're going to treat you special, right? But there is a problem with that. And the problem is there's too much knowledge in the world today. And so if a physician wanted to stay up to date, they would have 20 articles every day, 365 days a week. That sounds miserable. I'd rather have them treating patients, right? And then there's this other issue of complexity. There's this kind of this concept of the magic number 7, that you can factor in about 7 variables, plus or minus 2 if you're brilliant, are factoring in all these things, but then there's more and more diagnostic testing, more and more imaging, and so there's just too many data points for them to make a cohesive decision and make that decision correctly every time. So you see there are limitations in how medicine is traditionally practiced. And so what you can see here is that the result of that is huge variation. Depending on if you see physician A versus seeing physician B on any day of the week, you may, with a single condition, get different results. And the implications of this are there's huge safety risks and huge opportunity costs, right, in how medicine is practiced. For example, if a doctor tends to always give a lab that's unnecessary, they'll give the lab for like thousands of patients, and that is a waste, right? It is a waste on the economy, it is a waste on the system. So here's a quick example of a study that was performed in looking at just variation, right? And so this was looking at complicated pneumonia and how they were treated. You'll see that there's basically 3 different ways in which complicated pneumonia is treated. It was shown in these 3 colors, right? And basically, what is the lesson here? The lesson here is bars do not look alike. Right, so depending on which hospital you go to across this graph, you get treated differently. Now, do you think that's good medical care or bad medical care? Bad, right? Because there's a right thing to do, and there are some hospitals here that are doing the wrong thing. So what do we do about that? We've actually turned to another industry. You turn to manufacturing. Because manufacturing, if you think about it, is an industry in which they're able to produce the same good one after another, right? And in some cases in healthcare, we want to be able to do that, have that consistency, right? And so these are 3 key players in terms of the development of both manufacturing as well as quality improvement that happened early in the 19th century. So you have Frederick Taylor, Walter Schuh, Edward Deming. And Frederick Taylor was really talking about the assembly line. Okay, and basically saying that if I have a really smart, let's say, engineer, okay, he can develop the perfect process, optimal process, and you just find workers to work the assembly line. Right? Think about a car production assembly line where you start with the body, and then you add the doors, and you add the wheels and the tires, right? You only really have a handful of people to process, right? And then you have the people who just plug it on the car, right? And you're like, okay, well, I think that'll work. But what's the problem here? The problem here is that when there is increased complexity, the assembly line does not work, right? And if you know a system, have you guys heard of the Toyota production system, right? They actually changed, right? They changed that the workers on the line have the power to stop the line. If they know there's something wrong with a car, they will stop the entire assembly line, right, and fix it. So not the engineers fixing it, the workers are producing the solutions to fix it, right? If you think about Taylor, right, and then Deming, which is more of, which is where Toyota Production System got a lot of its ideology, right, is Taylor is this top-down methodology, right, and thinking that a person has come up with a perfect process, right, and then they're going to enforce it on the people that actually carry out the process, right, and they're going to incentivize these people, right, either say, if you do a good job, I'm going to reward you. If you do a bad job, I'm going to punish you, okay? While Deming, on the other hand, took this bottom-up approach, and it was more about how do we make your work meaningful? He has this concept called joy in work. Now, I don't know how many of you guys actually like, let me rephrase that. I don't know how many of you guys like to go to school, but if there was a way that they could make learning, right, match maybe what you want to accomplish, right, in terms of giving you the right opportunity or setting up the process so that you learn at your pace or in your style, or if you work in a way in which you are motivated and you're able to change how you work to be able to accomplish your personal goals, right, then that sounds like something that would really work, right? So that's kind of what Deming was pushing in that how do you make changes or how do you build a process that fits with the workflow of the people and allow the people to be able to contribute to that, right? So there's this concept of the leader as a servant king, right? So the leader's job is not to slave the work, them up and empower them so that they can contribute to improving a process, right? And the second part is how do you build tools that fit in with workflow, right? How do you make it easy to do what's right and hard to do what's wrong, right? And one of the things that you'll learn from this talk is the importance of teams, right? It's the people who do the work that really have the knowledge. The engineer had the plan, but once that plan is done, right, it's the people who do the work who really know what's going on. And that's what you're going to learn as I talk about how that applies to healthcare. Okay, just a little bit of math. Okay, just a little bit, some real basics. Sure, you've seen this before, Gaussian distribution, normal curve, right? Because one of the key things in quality improvement is measurement. Because only measurement and data can convince somebody to change, right? Improvement is about change, and only data can do that, right? So here is a normal distribution, right? And you have your first standard deviation, second standard deviation, third standard deviation, so 3 sigma. And so if you're at 3 standard deviations, you're within 9.7% of. So in quality improvement, we actually rotate the curve and add a time series, right? So now you're plotting a graph across time of a process. And so what you can think about, going back to that 99.7%, is that when your process comes up here or goes down here, something strange is going on with your system, and we call that special cause. And so 0.3%, right, 0.3%, something is going on, right? And so if we measure a process, right, it's going up and down, it stays within these limits, you're like, okay, well, looks like this is just normal variation, nothing to be concerned about. But if the process suddenly jumps in this 0.3% range, you're like, hey, I need to go investigate what's going on, right? And this is data telling you what to do. The other thing it tells you is what not to do, right? So if you look at the couple points here, suddenly it drops. And if you have a boss, the boss might be like, hey, let's say our sales numbers have fallen this month, you need to go investigate, right? You stay up all night, you're looking into it, and in the end, you have no explanation, right? But if you were measuring it this way, you'd be like, well, this is just normal variation. This is actually nothing to be concerned about, because look, the following 2 months, we're back up, right? So this is why it's important to kind of have this data framework as you think about processes and whether or not to change them. Again, you can have a process and it could be really crazy, but your improvement isn't so much to change this line, but it's actually to reduce the variation so it's more predictable, about what your process is like. Does that make sense? All right, so some quotes. Every system is perfectly designed to get the result it gets. Wow, that's profound, right? And so, but then a lot of times the results aren't what you need, right? And so what do? You need to change the system, right? It's not necessarily about the people in the system, but the system itself. And so how does this apply to healthcare? I have two examples today, but first I'm going to give you just a little transition into how that applies to healthcare, okay? So first, there's the Institute of Healthcare Improvement, which is one of the big bodies in healthcare talking about improvement. And they have three aims. They have this thing called the triple aim, in which they look at if you could improve across all three of these dimensions, population health, cost, and patient experience, that sounds like great healthcare, right? You're reducing how much it costs to have healthcare, and overall, everyone is getting better quality care. And so these are some of the concepts of improvement that you can then kind of apply to healthcare itself. So the first is acknowledgement is bad, in that to do the same, than to do it right. Now, if you talk to your doctor and said, "I want you to do it wrong just like everyone else," they'd be like, "What? No, I do it right, and all my 10 other colleagues do it wrong." But the thing is, you have 10 people who are doing it wrong, right? How do you get them to change? You can't get them to change until everyone does it the same, and everyone can figure out how to do it right together, right? The second part is you have to measure the outcomes. Right? You have to measure, and doctors are kind of like scientists. They love data, and you have to give them feedback to basically say, this is how you're doing, right? And this is how you're doing compared to everyone else, right? And that will be a motivation for them to change. And we have this theory that if quality improves, safety will improve, and costs will go down, right? The US healthcare system, to be in the hospital, the number one killer, the number one cause of deaths in the United States is not airplanes, it's not car accidents, it's not anything. It's actually going to a hospital and dying there due to safety accidents, right? Due to infections that happen just because you're in a hospital, right? And so by improving quality, we expect that safety will improve because everyone will be doing the same thing and following the same protocols. And costs will go down because variation will shrink. So think about if Dr. A prescribes a cheap medication and Dr. B prescribes a expensive medication, right? Then when I'm contracting, if you think about supply chain, you business people, right? I'm having to contract across both medications, right? If I can standardize and say, we're only going to use this one medication, right? Then we're going to reduce costs, right? Because we can get volume discounts and things like that, right? Some economies. And then most of all, the success project, quality improvement project, depends on the team, and I'm going to give you a couple examples of what that looks like. First of all, improvement doesn't happen overnight. It's not, you do this one big thing, but it's actually doing really small things over and over again, looking to see what works. So, how do you approach an improvement problem? So first, you have to find what the problem is. What are you trying to improve, right? Then you diagnose and kind of say, okay, well, if we're trying to improve this, we set this goal to reduce maybe the number of days you spend in a hospital. Okay, well, what are some things that you can do to affect that? Right? Well, we can make the surgeons perform better. Okay, well, let's. Okay, so that's that theory, right? And we have maybe weekly huddles. Right? And once we make that change and we see some improvement, how do we then make sure we sustain that and then find something else to do, right? And so the point of improvement is these cycles we call PDSA, Plan, Do, Study, Act. And you run over again, right, to improve. So here's an example in the healthcare field of a standardized plan, right? And we call these clinical pathways. It really is if a patient comes in with a certain condition, in this case, it's if you have a urinary tract infection, these are the next 5 steps that the doctor will take to treat you, and then it'll kind of follow a decision tree, right? So the doctors have already identified what is the best protocol, best algorithm, right, to take care of this patient. And then we look for exceptions. So 80%, right, 80-20 rule, 80% of the patients will follow this protocol, and that's great, so you just kind of follow the steps. But then 20% of the patients, you can actually use your mind and think about, okay, well, this seems to be an exception to the protocol. How do I address that? And here's an example of a project. And so there was a project targeting children between the ages of 6 months to 24 months, in which we had a really high catheterization rate. Do you guys know what a catheter is? Okay. For those who don't know what a catheter is, it's basically this plastic tube that they stick into your body part to get your urine. Okay? Not fun. Okay? And what they identified was you don't actually have to do such an invasive procedure to capture urine, to do the urine test to see if you have an infection. You can actually capture urine just with a plastic bag. You basically put a bag on a baby and you capture the urine and you test it. Sounds good, right? And so that was the improvement process, right? And so they identified that there's actually a better way to do this, but how do we get people to change the way they practice, right? And so they started by meeting with nurses and saying, hey, we're going to try this new form of practice. Okay, and so here you can see kind of the way it changed. So red here, patients that were catheterized, and you can see that go down. And yellow are the people who previously would have been catheterized, but now they're being bagged. And so at the end of the project, you can see that this proportion has drastically shifted, right? You think the patients are happier? Yes, right? You think the costs have gone down? Yes, right? Because you're not using medical equipment, you're just using plastic bags to capture, right? And you're not having to use lab tests, right? And so here in the data, if you go back to thinking about the control charts I showed you, you can see if this control limit had continued, right? We've actually created a change in the system, and the system itself has changed. And so through each of these different iterations of improvement, we've been able to push the catheterization rate down from 70% down to about 25%. Okay, and so this is the evidence that the improvement has happened and the evidence that the improvement has been sustained. Okay. Now I'm going to give you another example in the ambulatory care setting. So we have a large care network, so our community, right, where we see kids for primary care, we have about 30 practices in which we prescribe antibiotics for many, many conditions. Now the problem with antibiotics is you can have narrow spectrum antibiotics, which can target certain bacteria, or you can have broad spectrum antibiotics, which can wipe out all sorts of bacteria. What's the problem here? The problem here is if you overprescribe broad spectrum antibiotics and kill all bacteria, the bacteria will actually become more resistant to antibiotics, just in the community overall. So this is a huge public health concern. And so when the next time your kid or your friend needs antibiotics and they give it to them, the bacteria is now resistant to that antibiotic and no longer effective. So it's really important then for the physicians who prescribe antibiotics to always be prescribing the appropriate antibiotic. The other thing that's really interesting is how to change physician behavior. Right? I talked about how physicians are really smart, they think they know what they're doing, and yet they're also data people, right? And so we did the study in 2010, a research study, in which physicians were prescribing antibiotics at this rate, and then when we started to give them data about their prescription practices, they actually dropped. They actually got better at prescribing narrow spectrum antibiotics. So this project targeted 4 conditions. I won't read these to you because just know that conditions, and basically looked at a couple of measurements. Increasing the use of amoxicillin, which is a type of antibiotic, which is one of the narrow spectrum antibiotics. And then looking at how much we were spending on antibiotics. But then at the same time, you have to think, if I'm going to focus my improvement on this one thing, I also don't want a bad thing to happen when I'm not looking. So what's the bad thing that can happen if I'm focused on just prescribing medication? what could happen is that I missed something. Maybe I'm misdiagnosing, right? And so what could happen is people could be like, they see a doctor one day, and then 5 days later, they have to go to the emergency department because they got even sicker because we gave them the wrong medication, right? And so we were measuring that as well. And so, again, thinking about improvement is starting small, right? Just testing to see if something will work. And so the first phase of our test was to just start with one condition, focus on one condition, and start with 3 different clinics, right? And then we worked with the doctors there and basically said, hey, go look at your peers, your colleagues, look at the past year of prescription patterns, and tell us, what's wrong here? Like, what's going on in how you're prescribing, right? And they came up with some ideas, right? And then we brought an expert in to basically educate them in what is the right thing to do, and then we gave them data, right? In phase 2, we expanded that to all 30 practices across all conditions. We gave everyone data, and then we also changed the medical records, so the computer system in which all the patient's records are logged. And we basically said, if a patient comes in with this, and you want to prescribe this X antibiotic, think about it, right? Don't prescribe the broad spectrum antibiotic, right? And so I talked about earlier about how make it easy to do the right thing, but make it hard to do the wrong thing. And here we're trying to make it hard to do the wrong thing. And so it interferes and blocks the physician workflow, okay? And then last of all, again, we give them data. So what does that look like? So we give them, the education piece was having an expert come and talk to them about what's the best practice, right, to convince them. And then we also educated and sent out information to just the entire community, to other clinics that maybe weren't part of our network, but also to families, so that when families come in, they don't ask for the really powerful antibiotics. They understand that they want to get the best and the right antibiotic. And so that's kind of what this looks like. And then we also have a report card, right? Basically to show how they're doing. And how they were doing. This is how they compare to their peers. And then this is how they compare to everyone else. Now physicians, I don't know if you know any doctors or medical students, they're very competitive, right? And they want to do better than everyone else. And to take good care of patients is a good thing to be competitive in. And so this data helps drive that incentive. And then we educated the families as well. And here you can see an example of pneumonia basically changing, right? In phase 1, you can see there's some improvement that happened. And then in phase 2, you can see some more sustained improvement, right? And it's, again, above this control limit line, right? That's what the data is telling us. And then again, I talked about the balancing method to make sure that we're not else. You can see using data again that nothing has happened. This is just normal stuff. And again, a really important thing is actually financial outcomes. So what we found was focusing on low-cost antibiotics, we're actually able to save money. And so we're able to save money around $78,000, $80,000 a year for the families. Right? So these are all, if you think about that triple aim I talked about, these are all really great things. And so how do you sustain this? Right? And so really, if you think about the concept today, it's really about how do you incentivize people to be involved in quality improvement, right? So one is obviously some financial motivation, right? You give them data, right? But you also, the key thing is this physician champion, is the people doing the work. We talked about the team aspect. The people who are doing the work need to be involved in improving the work, right? So in summary, quality improvement just in general, right, is around reducing variation, right? Trying to standardize the way care is delivered or the way just things are done, how processes are done. You have to measure what you want to measure. You can't convince anybody that there's a problem. You can't convince anybody that they've succeeded, right? You need to engage the team itself that actually does the work. Right? You need to give the team a voice, right? Because they're the ones who do the work every day, and they're the ones that have the best ideas. And last of all, you have to innovate. You have to be willing to try things, right? And if you fail, you have to try again, right? Even in the startup world, in terms of from an entrepreneurship standpoint, right? Only 1 out of every 10 startups succeed, right? But you have to be willing to innovate in order to really change and improve on the way things are, right? I hope that was interesting to you. I have a couple of resources here, but for any questions.